Hi, I'm Patrick, and I'm your narrator and presenter for this informational video on Sertraline. This video has two parts. The first part will be a plain language summary tailored towards what you should know as a patient taking Sertraline, while the second part will be more of a deep dive into the drug's properties and monograph, suitable if you're a professional or student in the medical field. A timestamp that you can skip to is on screen for your convenience. So then, let's dive right in. Sertraline is a medication also known as the brand name Zoloft. It is typically used as an antidepressant, but is also used to treat other kinds of mental disorders such as PTSD or social anxiety. It typically comes as a tablet, though you might find it as a liquid in special cases. Displayed on screen now is what a label from a bottle of Sertraline might look like at the pharmacy. To take Sertraline, simply take it like a normal tablet by mouth. Ideally, take it at the same time each day, so that the amount of drug in your body is consistently stable. You can take it with or without food, whatever works best. As for storage, keep it in a dry, room temperature place, out of the reach of children. A bathroom medicine cabinet is a rather poor choice, usually because the increased moisture can make its way into an unsealed bottle. While taking Sertraline, the following is fairly common to expect. Because of how the medication works and what we know based on other people who have taken it, the benefits of taking Sertraline might not kick in until you've taken it for at least 2 weeks. The full effect of your current dose usually takes between 4 and 8 weeks to realize, so if you think you need a higher dose, wait until after 4 to 8 weeks to request a follow-up with your prescriber's office. As for side effects, the most common ones are listed here and aren't too intense. Nausea, dry mouth, and abdominal pain are common symptoms from a lot of different medications and causes, and this one is no exception. On the other hand, decreased libido, which is the feeling of indifference or lack of enthusiasm for sex, is one that's not as common to other medications but does apply here for Sertraline. As with any medication, these side effects are possible ones and aren't necessarily guaranteed, especially if you take a lower dose that is still effective for you. You can always ask your prescriber to help lower your dose or find alternatives or solutions if these get in the way. Now, Sertraline does have a couple of rare but serious things to watch out for. You should seek emergency help immediately if you experience your mood getting worse or have thoughts of self-harm. You should also seek emergency help if you experience signs of a condition called serotonin syndrome, which includes feeling agitated, sweating profusely, feeling like your heart is racing or beating extremely fast, and having confusion or hallucinations. Now, while most medications can be stopped safely, if you no longer feel the need to take serotonin, you should call your prescriber for help with decreasing your dose gradually. Suddenly stopping serotonin can lead to uncomfortable or dangerous withdrawal symptoms. That about wraps it up for part 1. On screen is a summary of what I just went over, including what serotonin is, what it's used for, how to take and store it, what to expect from taking it, and what to watch out for. With that, that's all for part 1. Part 2 may contain content that is hard to understand without a medical background. If you have any further questions about serotonin as a patient, call or see your local pharmacist or prescriber for a consultation. Welcome to part 2. Let's take a deeper dive into what to know about Sertraline as a medical professional. Sertraline has FDA indications for MDD, OCD, panic disorder, PTSD, PMDD, and social anxiety disorder. Sertraline does see off-label use in treating dietary disorders, such as binge eating, body dysmorphic, and bulimia nervosa. While there is an FDA indication for social anxiety disorder, Sertraline's use in generalized anxiety disorder is off-label. Now, interestingly enough, the libido-decreasing adverse effect is harnessed for off-label use as a treatment for premature ejaculation. Sertraline falls into the SSRI class of antidepressants. Its mechanism of action is shared with its class in that it inhibits the reuptake of serotonin, commonly abbreviated 5-HT for 5-hydroxytryptamine. The inhibition occurs presynaptically. This increases the concentration of serotonin lingering in the synapse, and increases the chance of it being received by the postsynaptic neuron to continue signal transmission and its downstream effects on the serotonergic pathways. Besides the standard hypersensitivity contraindication, MAOIs are not to be used concomitantly with Sertraline, with the washout period being at least 14 days or 2 weeks from stopping MAOIs. Pimozide is also a contraindicated combination. Disulfiram is a contraindication, but only for oral solution dosage forms of Sertraline. Now, the black box warning for sertraline is for suicidal thoughts and behaviors. Antidepressants in general increase the risk in pediatric and young adult patients especially. I'll touch on this again in the monitoring parameters. The other warnings on the FDA monograph begin with serotonin syndrome. As expected, concomitant use of other serotonergic agents increases the risk of this adverse event, which can even happen with sertraline alone. Sertraline also carries an increased risk of bleeding, stacking with the likes of NSAIDs, anticoagulants, and antiplatelets. Patients should be screened for bipolar or dissociative personality disorder to manage the risk of mania or hypomania. Sertraline should also be used in caution or avoided in patients who have seizures or untreated angle closure glaucoma. It is also a medication that can prolong the QT interval, so be mindful of that. As mentioned before, of course, sexual dysfunction can also occur due to sertraline use. Other known interactions include agents acting on CYP3A4 and CYP2B6, as sertraline is a substrate. On the other hand, sertraline is an inhibitor of CYP2D6, so be mindful of drugs that interact with those. Sertraline is also known to increase the phenytoin concentration in the body, and may turn up as a false positive in benzodiazepine screenings. It also is highly protein-bound, and so it will share space with other protein-bound drugs in the bloodstream. Listed here are the most common adverse reactions in the prescribing information highlights on the monograph. The most likely serious reactions have already been covered in this presentation previously, so I won't go over those again. As for dosing in adults, consult the graphic on screen now. Pediatric dosing is available, but won't be covered in the scope of this video. For dosing adjustments, there is a 50% reduction for hepatic impairment based on the Child-Pugh score, 5 to 6 specifically. There isn't any adjustments for renally impaired patients, however. To titrate doses or switch antidepressant agents, wait for the full effect of a given dose to manifest before making a judgment call, which typically happens between 4 and 8 weeks. For monitoring, efficacy can be measured by the mental health assessment scores at follow-up compared to baseline, as well as the patient's overall satisfaction and well-being. Safety parameters to monitor for include the previously listed adverse effects and clinical worsening or mental status changes. This is particularly important to monitor in the initial 1 to 2 months of therapy or during a dosing adjustment. Overall, sertraline's place in therapy is securely seated as one of the initial agents of choice in treating major depressive disorder. Its relatively tame safety profile is notable among its peers, but it is not without its faults. Concerns regarding QT prolongation, bleeding, and serotonin syndrome remain present in the background, alongside its hepatically dependent clearance. Plus, dose titration is time-limited by its 4 to 8 week realization period, like other antidepressants. Its efficacy is actually comparable with other agents within and between classes of antidepressants. This doesn't necessarily swing it one way or the other, but it does take time to tell whether this ends up being an agent of choice for any given patient. That's all I've got for you for this video. Thanks for watching. And for further information, all references used can be found cited on the sections introducing their material. This video was produced and recorded in January 2022 and reflects the current state of available knowledge on the medication and its properties at this time.